Hello everyone. I'm very happy today to share my talk on implications of comorbidities in Chiari malformation. My talk will be an anecdotal and descriptive way, reminding us on the comorbidities and also reminding us that those apply to Chiari across ages. That's why I'm showing MRI samples of people at different stages of their life, from a 3-year-old to a 33-year-old, and reminding us on the lifelong implications of Chiari. The take-home message will be that we have one phenotype that is associated with a spectrum of various acquired and congenital comorbidities, and if those are overlooked, it definitely has effects on our outcome, both in regards to medical or surgical management, and also often requires a multi-step and also multimodal approach to a person that's presenting with Chiari. Let's start with the cord. In the pediatric realm, the association with Chiari malformation and radiographic evidence of tethered cord has been established, and if there is evidence of tethered cord symptoms, for example, as in the 6-year-old with neurogenic bladder, left leg pain and weakness, and no evidence of headaches, but radiographic evidence of a fatty infiltration of the phylum terminale as seen on the MRI, probably the most relevant and important approach would be sectioning of the fatty phylum to treat the neurogenic bladder and also the leg pains, and then monitor the Chiari. In the pediatric literature, there is case series evidence or anecdotal evidence showing that more often than not, there is a low positioned conus, which was defined as the conus at L2-3 disc space in patients, in pediatric patients with Chiari malformation, and those have presented with a higher prevalence of a syrinx. And it was proposed also with the other publications that I'm mentioning here that sectioning of the phylum is a very reasonable approach. And the 2005 study presented by the authors Royo Salvador also proposes phylum section in Chiari children with syringomyelia and scoliosis. To support that notion, I'm presenting a case here, an 11-year-old post-Chiari decompression, where in addition to successful Chiari decompression, also phylum sectioning was needed based on a persistent neurogenic bladder, progressive leg weakness, and the neurological finding of an increased leg tone. And that child presented with a conus at the L2-3 level. Without a fatty phylum, however, phylum sectioning was promoted given the above symptoms and the radiographic evidence of a low-lying conus. This is a classical example of the multi-step and multimodal surgical treatment algorithm in Chiari malformation and associated tethered cord syndrome. Let's go to the next comorbidity, craniofacial syndromes and craniosynostosis. Certainly, craniosynostosis are sometimes more subtle, particularly in the non-syndromic craniosynostosis cases, where hidden comorbidities are likewise subtle. In syndromic craniostosis, it is well known that they often present with hydrocephalus, syringomyelia, and/or venous hypertension, given the tightness of the skull base due to the abnormal head shape that also affects venous outflow and has implications on the fluid and cerebrospinal fluid absorption and circulation. In the non-syndromic craniosynostosis, there are case reports that support, again, a multimodal treatment for the associated CSF disorders. Amongst them is Chiari Malformation with syringomyelia, where they show that a third ventriculostomy failed and the child needed Chiari decompression. And in other reports, the incidence of Chiari malformation can be quite high, particularly in isolated lambdoid synostosis, as high as 55%. And in sagittal synostosis, there is a pretty impressive finding or prevalence of syringomyelia in 30% of the patients, and that prompted additional Chiari decompression on top of the craniofacial repair. These three patients should provide an example for the spectrum where Chiari presents with sagittal synostosis, metopic synostosis, and even persists in status post left coronal synostosis repair at 6 months. And also, when you look at the symptoms, you do see that with the multidisciplinary approach, how different aspects of biomarkers of intracranial pressures are looked at and seen. First patient with a sagittal synostosis actually presents with extensive syringohydromyelia, and a Chiari decompression was then done in an outside hospital and institution. And I present the management of the second and third case done here in our hospital a couple of years ago. The 7-year-old female mainly suffered from occipital headaches, activity and Valsalva induced, and also for a just mild cosmetic concern, and no other developmental and cognitive delays seen during a neuropsychological assessment. We opted for Chiari decompression to treat the headaches. And you can see the pre and post-op MRI to demonstrate the result of the surgical decompression. And this patient did very well with the headaches post-surgery. The 6-year-old male had a total cranial vault remodeling. This was the child that had a left coronal synostosis repair when 6 months, and presented then later on with significant developmental delay, and cognitive limits in various domains, and also papilledema, indicating global intracranial pressure, and certainly also microcephaly. And we did a total cranial vault repair with widening and adding occipital cranial volume. The next group is people that present with additional craniocervical skull base alignment pathology and malformations, which are certainly not the most straightforward patient group. Not to say that anything of what we're dealing with is straightforward. However, this is an example of needed correction of the alignment of the skull base in order to safely and also efficiently address the brainstem compression, as seen here in a 17-year-old that presented with headaches, neck pain, also blurry vision, balance problems, and has a family history of Chiari. Her mother had treatment in 2012. And you can see here the pre-op picture, also showing the ventral brainstem compression due to basilar invagination. This is just the example of radiographic evidence showing the instability based on the increased distance between the axis and the atlas on the lateral CT scan view, and the invagination of the dents into the foramen magnum, supported also by X-rays in extension and flexion. A more enlarged view of the X-Flex study done in that patient, supporting the amount of instability at the skull base in the occipital axial atlas region. Not anything new to you, but just showing that there are certainly different ways to manage the optimal alignment at the craniocervical junction, and usually in the pediatric realm, a halo is placed that models the correct alignment and also symptomatology with correction of the angles and assessing the tolerance of the patient. And you can see on the lateral CT scan the correct position of the dents in relation to the clivus, and then the surgical result on the right hand with Chiari decompression and post-occipital cervical fusion. In patients with hypermobility syndromes and connective tissue disorders, we all understand now the value of the upright MRI that shows a more relevant picture of the cranial base, including the settling of the skull base with the allowance of gravity. And I'm presenting two examples here. One in a healthy control subject showing extension and flexion, where you can actually see how the relation of the cerebellum to the skull base as well as the brainstem changes with extension and flexion. And we have never really appreciated how much there is movement of the cerebellum as well as the cranial junction of the brainstem and the cervical cord in the dynamic setting. And the lower MRI does show a person with Ehlers-Danlos syndrome and extension and flexion. And you can see, in addition to the relative movement of the spinal cord and the cerebellum, you can also see obstruction of the subarachnoid space at the level of the junction when the person extends. This is a T2 weighted image, and you can see that an extension, the CSF space anterior and posterior to the brainstem and the cervical medulla is compressed, which might be relevant and indicate obstruction of the cerebrospinal fluid, and is a indicator or biomarker of Chiari-like symptoms occurring in those patients. This can't be just explained by bony anomalies, and it wasn't until we started treating people with connective tissue disorders or becoming more aware that we realized how much we underappreciated the ligamentous factors. And one of those are the ligaments that attach to the dura on the one side and to the muscles on the other side, the so-called myodural bridges. And I'm showing here an anatomical drawing of those, indicating the location and the abundance of those connective tissue disorder bridges at the base of the skull that connect the suboccipital muscles to the bone, mainly the foramen magnum and the suboccipital bone, and then to the dura. And these are probably very vital structures, actually, and they adjust the thecal sac to movements, particularly in extension and flexion. And those myodural bridges are thought to stabilize the dural sac during head and neck movement and also promote cerebrospinal fluid motion. And there might be more involved in diseases than we have ever appreciated. And the Chinese group around Dr. Zhang have really pioneered the understanding of those myodural bridges and their role in neurological diseases. Realizing that, and also from the known finding in upright MRIs, or interesting finding in upright MRIs that I had shown you before, we tried to establish a more hands-on, real-time, simple method to allow assessing the subarachnoid space at the level of the craniocervical junction and indirectly show the function of the myodural bridges. And I show here some of the findings that we published a year ago in the Journal of Neurosurgery Spine, where we applied ultrasound in a control group and people with EDS at the craniocervical junction. And you can see here that in the control people, you actually do see, when they extend the neck, a widening of the space between the dura and the spinal cord, as you can see indicated by the white bar that becomes longer and enlarged. And then in a person with EDS, you can see that this is not the case in extension. you see that the white bar actually becomes shorter, and also somehow the picture becomes a little more hazy, and both the nerves and the spinal cord are not well delineated, showing that there might be some chaotic motion going on there. Remind you that this is real-time ultrasound, and certainly does show real-time movement as you do the assessment. This is a little bit of a busy slide, but that also should show you the dysregulation of the subarachnoid space at the craniocervical junction in people with EDS. When we did our ultrasound, we measured the difference of the subarachnoid space in neutral versus extension and flexion for each subject. And positive means the space is widened, negative means the space is narrowed. And as I have shown earlier, in control subjects, when you extend your neck, your subarachnoid space is widened actually, and probably allows more fluid circulation. And you can see in the lower line of our graphs, in extension in people with EDS, you see it goes both ways. It narrows, it widens, but there's a big heterogeneity in all the individuals, that you can say that there is no characteristic pattern, and some individuals actually extensively narrow their space, going into minus, which certainly might apply to symptoms that they have with neck extension and flexion, as we all know it when we are seeing these patients and listening to the complaints. And to provide some understanding what might be the cause of this abnormal laxity of the mydoid ridges and biological behavior, we had shown evidence, and that's published too, about dysfunction of the collagen fibrils in people with EDS. These are electron microscopic pictures, and you can see on the A-B slide how normal collagen fibrils should look like. They have these periodic D bands, which is consistent with normal collagen structure, and also well-organized collagen bundles. And in people with EDS, the transmission electron microscopy of the collagen fibrils shows that they are swollen, disorganized, showing a corkscrew pattern, which is consistent with dissolving collagen fibrils and disintegrated and denaturated collagen fibrils, which speaks to the loss of stiffness and elasticity and to their dysfunct nature. These were mydoid bridges specimens that were harbored during standard and routine Chiari decompression, and these are ligaments that are routinely dissected off of the dura when we do our standard Chiari decompression, and we studied them then using transmission electron microscopy. A short word to idiopathic intracranial hypertension. Its diagnosis is established by headaches, visual decline, often but not always seen with papilledema on eye exam, and the population has usually an increased BMI. often the venogram with contrast is more relevant to the venogram biomarker of idiopathic intracranial hypertension, which is a narrowing of the sinus at the transverse sigmoid sinus junction, as shown by the arrow. But often even that is not necessarily seen and is not always accurate. And some interventionalists have started to do invasive angiograms to measure the sinus pressures along that junction, and a pressure gradient of more than 8 millimeter mercury indicates a functional obstruction, which might also be relevant to the problem. This picture should show you that if medical treatment fails, as listed on the right side, the surgical interventions are shunting versus stenting. Due to the nature of the sinus pathology, stenting is probably the preferred route. Certainly has its own risks. However, let's move on to intracranial hypotension. This is probably the most challenging, puzzling, and confusing syndrome, both for the person who experiences them as well as for the physician approaching it. Even though the headaches are of orthostatic nature and are found in almost 100% of patients, as is neck pain, there are a lot of puzzling symptoms that actually overlap with other systemic or neurological conditions. For example, nausea, vomiting, hearing abnormalities, as well as light and noise sensitivity, which are also found in hypertension. And then we have cranial nerve deficits, cognitive decline, and if a leak becomes more chronic, it can lead to dementia, and also spinal cord symptoms such as myelopathy, tremors, and can lead into coma if undetected. This is certainly very threatening, and the imaging is not always straightforward. Even though we try to find the leak by MR myelograms or more sophisticated high pressure myelograms and certainly brain MRIs, it's not always obvious. Leaks can be very occult and hidden. Dr. Shiving gave me the pictures and allowed me to share this in educational lectures. And from the left to the right, you can see myelograms of dilatation of the nerve root sleeve, ectasia, and dehiscence of the thecal dural sac, spinal nerve sleeves, diverticular, or even prolapses, or a distinct leak at the dural site. If those are found, of course, then you have a target, but they are not always found, and often you just have indirect evidence in the brain MRI as of hygromas, meningeal enhancement from the chronic hypotension and the negative pressure, as well as the sagging of the brain with brainstem sagging, cerebellar sagging, and swelling of the midbrain and the pituitary gland. Those are certainly diagnostic biomarkers, but they are not always obvious. And sometimes you have to do empiric management, as shown in the next slide. Treatment here is, in the first place, epidural blood patch, according to Dr. Shiving's data, with a 95% initial response and even actually 80% cure rate, which is meaning that you cure the symptoms. And certainly a high volume blood patch is associated with higher response rate. And for spontaneous CSF leaks, Dr. Shiving has gone as high as more than 100 cc's of autologous blood to be injected for CSF leaks, as They are certainly more difficult to treat compared to those that are found anatomically on neuroimaging that are amenable to surgical repair. Last but not least, a patient of mine that I treated lately that presented with debilitating headaches, frontal and suboccipital in nature. And this lady actually went to the emergency room and had this MRI of a congenital type hydrocephalus of chronic nature. You see the widening of the occipital horns, which speaks to the pediatric anatomical picture, and then the sagittal MRI showed Chiari malformation as well as an aqueductal stenosis. And she actually underwent Chiari decompression, given that a lot of her headaches were triggered with Valsalva, and she couldn't even talk anymore, given that louder talk and yelling increased her headaches. However, there were headaches that were not treated with the Chiari decompression, and now she will undergo a aqueductal stenosis, which now is probably more feasible given that the suboccipital area, as you can see on the right-hand MRI, is now decompressed with good anatomical reconstruction of the cisterna magna, and now she will be offered an aqueductal stenosis management with an endoscopic third ventriculostomy, which hopefully will also alleviate her hydrocephalus-associated headaches. This is an example how multimodal and multi-stepwise you treat all the other CSF conditions associated with Chiari. In summary, I hope that my talk gave you some food for thought about when we see a Chiari, our default button should be what's in there, and that we need a very individualized multimodal diagnosis and diagnostic approach to really look hard at the spectrum of the other comorbid conditions with focused imaging. And examples are the hypotension as well as craniocervical malformations and instabilities, particularly in people with hypermobility syndromes, and that often the approach includes suboccipital decompression, but also other treatments. For example, phylum sectioning and tethered cord, cranial vault repair in craniofacial syndromes, needless to say, instrumentation infusion in craniocervical instabilities, or hypermobility syndromes, stenting, shunting, and associated pseudotumor cerebri-like pathology, and blood patches and surgical repair for hypotension, and multimodal CSF interventions in people with associated hydrocephalus, as well as chronic hydrocephalus in the pediatric perspective. Thank you all, and hope you're all doing well.